want to thank you all for joining today's webinar, NACCHO 360 Behavioral Health State of the Union, brought to you by NACCHO's key strategic partner, Credible Mind. In response to the mental health crisis that we are facing in our local communities, NACCHO forged a partnership with Credible Mind, a behavioral and mental health platform to promote well-being. And since launching the program back in August of 2023, Credible Mind and Behavioral Health 360 have worked positively to effectuate change in over 200 local health department member communities. We've worked to boost access, reduce barriers, capture insights, and most importantly, we've made this available to communities and the public health workforce that we serve and who desperately needs this opportunity. Now, for our speakers, the first up I want to introduce Derek Van Brunt. He's a clinical professor at UC Berkeley School of Public Health and one of the founders and CEO of Credible Mind. So without further ado, I'll let him take it away.
Hi, everyone. Great to be with you. And let me introduce my colleague and co-speaker, Shamar Clements, who's one of our senior managers for research and translation at Credible Mind. I want to start by just two comments. One, a big thank you to NACCHO for not just hosting and organizing this webinar, but for their leadership around this critical topic of mental health in the United States. Shamar and I are really excited about sharing information with you that we've been gathering from this Behavioral Health 360 program that we're going to talk to you about, and sharing insights that we've never shared before because we've reached a critical mass of data that we feel now that's worthwhile to share this. So thanks for joining. Here's how we broke out the flow. We're going to start with just a snapshot of mental health and being in the United States. We're going to be looking at the traditional sources that you folks all see: NIH, CDC, Mental Health America, Gallup, APA, etc. It's just 3 or 4 slides, just so that we're all on the same page of what we'll call the snapshot of mental health as most people are seeing it here in the United States. Then we're going to really look at what we'll call the Behavioral Health 360 program, which is public health's response, where we're launching platforms and adding early intervention and prevention in the area of mental health. And we'll talk about what's making these platforms successful in local communities and what we're learning from the data about communities. And then finally, I think at the very end, we have one slide just for those of you that aren't that familiar with the program or want to get involved. You'll have next steps if you want to learn more. So before we dive into the national data, we've got several hundred health officials here on this webinar. And the work we're doing with Behavioral Health 360, we liken it to a learning community. We're all learning together. We're learning more from our partners in the field, I think, than they are from us. We're going to run 2 poll questions today. And let's see what we're all thinking about when it comes to mental health and behavioral health in your community. And you can read these different responses. Let's just start with the heaviest hitters. More than 2/3 of us want to improve care access, which makes great sense. And we're going to talk about exactly how you can do that, by the way, in this presentation. And then also putting prevention strategies into place, which is probably the other most important thing we're going to talk about. We will be talking about some measurement and addressing some of the challenges of workforce as well, and coalitions. So we're going to be covering all of these. That's very interesting to see the distribution. So the last thing I just want to say about our agenda is, I'll call it the big picture, which is, if there's a framework for the discussion that we're having today, it's that as a nation, we need to move away from simply a reactive system of care when it comes to mental health and being in the United States, and move to a population-based system of mental health care. And all I mean by that, and as public health officials, we know what this means. It means adding prevention and early intervention along with the clinical services in a seamless system that's available to everyone, both for our workforce and the communities we serve. That's what we're going to be talking about. That's what's taking place right now around the country. So let's start with some of the national data. A running statistic for some time now is that roughly half of adults have a diagnosable mental health condition sometime during their lifetimes. That's not what we're looking at here. This is snapshot data. This is current as of a period of time. And these numbers are quite high. Just under a quarter of Americans reporting not having a significant mental health issue at that time. That's higher than normal rates in response to that question. A quarter of adults that have frequent mental health challenges are saying that they lack access principally due to cost. And of those, about 10% have insurance. It just doesn't cover mental health services for them. And then perhaps the most alarming is, as we're going to look at and we unpack some of this data, is the impact on our youth, with 20% during this poll saying that they've experienced a major depressive episode. These are our kids, and these rates are all up from what we'll call the running rates up until the pandemic. And we're going to talk a little bit about trends in a moment. So let's unpack this a little bit. On the right, you've got an NIH poll measuring the prevalence of reported, and this is, they ask screening questions. So it's not just a quick question, it's you answer screening questions. So this is pretty accurate information here on the right. And we can see that the topics that are being reported the most are anxiety and depression. You can see the other topics listed there as well. But over on the left, let's open up that anxiety number and what's driving that. And the things that people are reporting are current events, the economy, the election, and gun violence. So that's a lot of what's going on in your community with the anxiety that people have. People are saying that stress and sleep are having the biggest impact on their mental health. No surprise there, they do. And then finally, very sobering is this bottom stat on the left, which is roughly a third of people in the United States live in what we'll call a mental health workforce shortage. If you're familiar with the concept of a food desert, we have mental health and behavioral health professional service deserts. They tend to be a little bit skewed in rural communities, but they're spotted all over the country. And it creates stress on the system. And I think one of the opportunities we have is when we add more prevention and early intervention, we can help address some of that shortage. And we're going to talk more explicitly about that in a bit. And I will say that the numbers are, it's estimated we're about 250,000 behavioral health therapists short right now to handle current demand. And I've read, and I'm not an expert in this, that could get worse, maybe up to about 400,000 behavioral health therapists short about 5 years out. This is not trending in a good direction. Rates are high, workforce is low, and workforce is becoming even more strained. So I'm going to hand this over to my colleague, Shamar, just to give us a little bit more insight into the trend lines around these like depression. And also, these high rates are not equally distributed in our communities. What do some of these disparities look like? So we're all aware of that. Shamar, over to you.
Thank you. So as Derek was mentioning, even with the great shortage in mental health provision, we're seeing an increase in numbers of people in need of those supports and services. This is a study that was done by Gallup. It asks people, have they ever been diagnosed or told by a nurse or doctor whether or not they've had depression? And then it also asks about current depression treatment, whether they are currently receiving services. On that green line, you see all that fluctuation and increase happening right around 2020, 2021. And that line is again for lifetime depression. To better interpret that, anything that was happening before 2020, lifetime depression rates, there was an increase, but it was pretty slow and steady. And so that means that the fluctuations that we see in those 2 years are happening because in that time, more and more people are getting diagnosed with depression. And obviously, we were all impacted by the isolation, the unknown uncertainty, the stress that came with experiencing a global pandemic. And after that first couple of years, we see that the rates didn't have the same level of increase, but still are rising at a faster rate than they were before the pandemic. And then for the blue line, people getting treatment for depression, there is a slightly higher grade of the slope of increase after 2020. What's not shown here is some CDC data that didn't ask quite about diagnoses or treatment, but just asked about people's lived experience with things like uncontrollable worry, feelings of hopelessness. So things that are symptoms of anxiety or depression, but people who may not have seen a doctor or gone to get treatment. In those charts, we see that there was a big increase during 2020, 2021, and then it went back down actually and leveled out. So these are things that are part of the human experience, but we all have exacerbating factors like the pandemic and other things that were going on in the world at that time that show up in the data. So what do we do with the relationship between these two pieces of information? The thing that we're taking away with Credible Mind is that while people experience an uptick during COVID and things may have leveled out in terms of self-reported data, the data on diagnoses and treatment continues to increase because there have been major changes in terms of decreases in stigma, normalization around this information, around mental illness and getting supports for it, access opportunities such as the big opening to telehealth that happened in 2020, higher psychoeducation, social media being a platform where people are becoming more open, especially in youth populations, to sharing these struggles, even professionals using those platforms to disseminate information, and also solutions like Credible Mind, where people are being able to digitally and on their own time and in their own space access supports that they need. But like Derek said, there are great disparities within the group, and we'll look at these more. So Kaiser Family Foundation has this graphic that's a good, easy binary to look at. We're just looking at people who say that their mental health or emotional well-being are excellent, very good, or good, versus only fair or poor. So in that first category of breakdown of age, it's very clear that younger groups are the ones that are more likely to experience languishing, that are having more of a struggle with how they're managing their mood and their emotions. Next is household income. I think it comes as no surprise that as your income increases, some of those barriers to accessing care, to getting your needs met, to getting not just your needs, but also your wants, your hobbies, your interests, the things that bring you joy and help bring a flourishing life, those things are made more accessible with higher access to income. And we see those disparities and how they impact people's reporting of how they feel in this data. Another community that's highlighted here is the LGBTQ plus community. And it's really disheartening, honestly, to see how people who are living their lives, living their truths, being who they are, the societal impact on how they get to do that is having such tangible and visible consequences on their quality of life. And those numbers are only dwarfed by people who are reporting only fair or poor physical health status. There's a lot of factors there. We already know and touched on how physical health impacts our mental health, but also the ways that accessibility, stigma, autonomy, things that are external impactors to people who may have chronic, acute physical health challenges or disabilities, how that's impacting their mental health as well. Some of the statistics that aren't shown here but are substantiated by various sources is that when it comes to race and ethnicity, in America, Black and Latina groups are those with the highest increase of mental health challenges in recent years. So while everyone is on the upward trend of experiencing higher rates of mental health challenges, these two groups are the ones that are seeing those numbers raised the most drastically. So within the various groups and how they're doing with mental health, we also want to look at the access to seeking treatment. Back to some of the racial and ethnic demographics, but also gender demographics. Asian and Latina people in America and men in general are generally the least likely to seek out treatment. Not that they are going to have the least issues or having the least challenges with their mental health, but have the most barriers to or least comfort with seeking out treatment. So let's get into what some US adults are reporting about why they are not seeking treatment. On this graph, produced by a survey via Gallup, we see that affordability, again, as many of us already know, is the biggest reason by far that people are finding as a barrier to mental health treatment. Close behind that is difficulty of finding providers. People are, there just aren't enough to meet the need in the current state that we're in. Beyond those two reasons, things drop off a lot more and is a bit more variable between the different age groups. But we see reasons like feeling like treatment won't be helpful, thinking we can navigate our issues without treatment, shame and embarrassment. And these things, to my surprise, honestly, still are trending with younger populations rather than old. So there's still stigma and old held beliefs that need to be addressed around the efficacy, the stigma, and the perceptions around seeking out treatment.
Shamar, thank you. So those are national well-known sources, and it was a snapshot just to put us on the same page. Now let us move into sharing information that we haven't shared before. And first, we're just going to define what this Behavioral Health 360 program is. We're going to share a little bit of the demographics of who's using this, how many people, and how we drive engagement. And then we're going to share some of the insights that come from all of this. NACCHO and Credible Mind formed a partnership about a year and a half ago, August 2023. And we launched this program, which basically, and we'll define it in just a moment, is a digital mental health platform that can be deployed in communities, cities, counties, regions, even statewide. And just over 200 communities are currently participating in the program, with just under 300,000 individuals having engaged with the system and a little over 2 million minutes of time on the platform. And it's from all of this that we're gathering data that we can now start to share with you. And as mentioned earlier, we're at this 250,000 behavioral health therapists short. The president of NACCHO, Lori Trumbull Freeman, said a very interesting thing at one of her keynotes at the NACCHO 360 conference. And she said, clinically, we can't really treat our way out of this. We've got prevalence is too high. It's increasing. We've got a shortage in staff. We need to bring a public health lens to the behavioral health crisis. And that doesn't mean that public health takes over. It means that public health needs to step up and join behavioral health in this population mental health model. And that's what we're going to talk about. So this is just traffic. It's just straight traffic so that you can just get a sense of trend line. So that's going to go up, one, because more communities keep joining. That's accelerating. But also within a community, we're learning how to drive more traffic, more engagement. And I want to make one comment about the data that we're going to talk about. For the epidemiologists in the group, and that's some of my training, you have to be careful. This is exciting data, but this isn't like a random poll where you can generalize the results. We're not going to, as we share this data, just be aware, you have to be careful about not just automatically generalizing what we see. That said, we're reaching such a penetration, a prevalence of usage, that the data is quite meaningful at this point and is going to get more meaningful over time. At a minimum, it can create insights and hypotheses. And in some cases, I think we're actually identifying certain issues. So just wanted to call that out up front. Okay, all the green colored states have at least one community using the system. What are people looking at? They're the top topics right there. And on the one hand, a lot of these you would expect, right? So depression, anxiety, burnout, ADHD, stress, PTSD, substance misuse, those are all very important topics, and they're getting a lot of looks, a lot of interaction. But there are some interesting things I want to call out. People have a lot of interest in the more positive side of this. There are many people working to reframe the mental health area to be more positive, not just let's work on the language of stigma, but how do we actually engage people in pursuing the science of happiness? And that the term of art is flourishing. And that is like the music charts. Flourishing's climbing the charts. So things like flourishing, mindfulness, self-care, resilience. These are climbing the charts, and it's rewarding to see that people are exploring this. And of course, a lot of this is a self-fulfilling prophecy. When people launch these kinds of systems, they can promote topics, as you'll see in a little bit, and that's going to drive people's awareness and interest in these different things. Again, I'm just on quick demographics here, and then I'll show you a few screenshots for those of you not familiar with what this program actually looks like. This is just the breakdown of male and female, and I think it's very clear that females in general pursue more health-related information if you look at internet statistics and all they're out on Google searches, et cetera. But it's pretty skewed that way. And as you can see, also young females are particularly high. This is a breakdown of how are people coming in. This is very important for anyone who's trying to make change in a local community. And that is, people are going to be using mobile devices. You've got it's all one data set, but part of this data is a subset of the whole. So let me explain. On the right is just general community members that come in. And you can see the yellow is they're coming in on mobile. And you can see by age, clearly youth is just overwhelmingly mobile. But even when you start getting into middle age and older, it's more mobile than not. Now, why is that? Part of it is that these people are seeing QR codes in their community, or they're responding to a local digital ad. That's part of the awareness campaigns that we'll summarize for you in just a little bit. So that's how they're hearing about it. That's how they're coming in. Now, when you expand this and you look to the left, and you also not just look at the community data, but include our public health and behavioral health workforce data, meaning the workforce, you can use this program to improve the mental health of your workforce, not just all the residents in your community. Then you can see more people are coming on their computer, no doubt, because they would be doing that at work. Okay, that's just some of the demographic kind of information. What is this Behavioral Health 360 program? So I'm going to go through this very quickly. I'm just going to take a minute or two so that people have a visual. This is the framework for why the platform exists. As a country, we already do the stuff on the right. We provide therapy. We've moved a lot of that to be available online. We provide medication. We'll just call that professional services. And of people with mental distress, 3 out of 4 just want to know what they can do to feel better. We would call self-care. And maybe it's on behalf of themselves or a child or a parent, but they're just looking for what works. Roughly 1 out of 4 that have distress are actually seeking professional services. Often they just don't know better. So what we've done is created this behavioral health platform, which addresses the box left. All mental health topics, mental health and being, for prevention and early intervention for mental health, and find professional services, and it's evidence-based. So that's the framework. And this is the way we define it on one screen. It's a digital mental health platform. Basically, it's a website that you localize in your community. It becomes available to everyone in your workforce and all residents in the region. So no users paying for anything. And we have all of the NACCHO members are part of a community, so we can now benchmark. You're going to see some benchmark reports in a moment. So communities like rural to rural can see how their community is doing, acuity rates, utilization rates, what topics people are looking at compared to other communities that look like them. And then we're doing best practice sharing. How are we driving engagement? Who's doing innovative work? And we're going to share with you a few examples of those innovations that are working really well. So this is the program. It's a website with analytics and best practice sharing services to help you localize a system and immediately start making impact. This is what it looks like. And this is a highly malleable screen. The colors can change, the words can change. The branding is really whatever you want. It might be a public health branding. It might be you're working with a coalition. Maybe you've done a CHIP or a CHA and you want to make this whole program part of the instantiation of that, part of that program. So there are a lot of different ways that it can look. But at the end of the day, it's going to be, there's no programming or anything necessary on your end. It's made to look like what you want it to in terms of brand and focus of topics. It's what we call configurable. So what do you do here? There are about 15 features. I'm just going to show you 2 to give you the bottom line. One is you can look up different topics. You can do a search, you can browse. There are over 100 topics. And of course, you're going to see the kinds of things you'd expect, like depression, anxiety, PTSD, stress, burnout, substance misuse, etc. But also it's much broader than that because people in our communities are suffering from things that don't have just those labels. Something like I'm caregiving for an elderly parent and it's wearing me down, or I'm drinking too much and I'd like to cut back, or I have an anger issue, or I've been incarcerated and I'm re-entering society, or I'm lonely. So all of these kinds of topics, over 100 topics are in here. And what's behind the hood? When you go into a topic, you get like, this is anxiety. This is what we call a topic center. And you'll see very few words there. We want people to know that you're not alone and there are things you can do to help yourself. And before I click into what most people do at this point, I just want to highlight that this page connects to local resources. One of our partners is in Owensboro, Kentucky, and you can see River Valley Behavioral Health there. On their website, if you're looking at anxiety, you can see where the local services are. And you could have a whole bunch of different services available, and they're contextually linked to the topic you're looking at. You're looking at anxiety, and you bring up local resources related to anxiety. If someone's looking at housing or loneliness, you probably are bringing up different resources. So anyway, the point is we help you connect all that in so people can find things in your own community. But what a lot of people do, and let's just take an example here with anxiety, is they click on what helps. And this is where a lot of the evidence base comes in. We have looked at the research around what has been documented to help people reduce the symptoms of anxiety. And there are 14 things on this page. And so I have personal experience that a couple of these, sleep and creative expression, were very important to a family member of mine who basically we clicked on sleep. How is it that better sleep helps reduce anxiety symptoms? And then in their case, they were really interested in an app to help you sleep. And we vetted over 20,000 resources, apps, videos, podcasts, online programs, books, thought leaders, etc. And so you can click right into a high quality app to help you sleep. So 3 steps: pick a topic, find an evidence-based approach that's likely to help you, and find vetted resources to take positive action. That's the formula for one use case of how people use the system. Multiply that, put that in the hands of everyone in the community across all topics, and suddenly people are doing for themselves and helping, sharing with others what's working. The other thing that you can do is take assessments. This is the most popular feature on the system. People love understanding what their risk is and how they're doing. So there are over 20 of these. They're in a library. And so everything, and they're all destigmatized, right? Everything from the images to the phrasing, right? It's how deep is your sleep? Are your off days a sign of depression or anxiety? They don't take long. Most of these take 2 or 3 minutes. You click, you answer a few questions, you get a score, and you get a report that's customized for you. You can save that, you can take it again 6 months, 12 months later, and as you'll see in a moment, you can share those results with caregivers if you want. These assessments are very popular and they generate a great deal of data, as you'll see in a moment, because as you've got thousands and tens of thousands of people in your community filling out these assessments, you can almost see in real time what's going on, especially in response to maybe a local crisis, critical event like flooding or wildfires or violence, etc. The platform is available currently in, I did do a count, 38 languages. You can see them all here. This is really relevant because we're all trying to improve health equity. And part of it is just helping people understand this kind of information in a language that they understand. So that is just something to be aware of. This platform, this Behavioral Health 360 platform, basically has 2 products on it. What I just described is the main product. We'll call it self-care, helping your workforce and everyone in the community with evidence-based self-care. The second, I'm just going to show you two screenshots of, is called Smart Screen. They work together. And Smart Screen, there's some overlapping capabilities, but its focus is not so much self-care, it's on triage, helping people in your community find the right level of care. And the right level of care might be self-care. That's where they're related. So it's really, what is your acuity rate, your acuity for different things? And what are your treatment preferences? And then how to help connect you to resources, because often not only do people not necessarily know where to go, but the process is very cumbersome, the behavioral health intake process. So briefly, anyone in the community sitting in their living room on a phone in a language of choice like Spanish can just pop in, answer questions, and then be triaged to clinical services or self-care based on their responses. And the questions that they're asked are a combination of validated scales, GAD, PHQ, etc., but also we can customize questions for any specific community or behavioral health organization. So if you want to know where someone is, or like a zip code, if you want to know whether they have insurance or not, whether they prefer, if they're open to online therapy or they prefer bricks and mortar, all of these kinds of things can be captured so that people are being sent to the best places for them. We're going to tell you a little bit more about that in a minute. For the end users, they get a report, areas you're doing well, areas of some concern. And you can click on these and go into self-care. And you can also be sent to resources in the community, and they're specific to how you answered the questions. If you're at high risk for depression, you're seeing 988 and crisis lines. If you're moderate to slightly high risk, you're seeing local resources and maybe call centers. And if you're low to medium risk, you're going to see more sort of self-care resources. So all of these made very simple phone numbers, what to do next based on your screening, essentially. None of this is making a diagnosis. It's just screening and helping you in the next step. There is something rather clever, which is a little results code. And if you can text that to yourself or email it to yourself, and you can share that with a professional, and you can have that information go into a behavioral health intake process, think pre-fill out a form, and there's clinical views into that information to completely streamline the behavioral health intake process. You're going to hear a little bit more about a county that did that and the efficiencies and the improvements that they made by cleaning all that up. Okay, this system, when people take assessments, it generates tons of data. And this is just one snapshot. So we create data and give it back to our partners in 3 different ways. One is standardized reports. They're already pre-formatted. You don't have to do anything. You just see the reports. The second is there's an online real-time dashboard. So you can put in date ranges, certain populations, certain regions, certain topics, and immediately get reports. You're going into a Board of Supervisors meeting next week or the next day, you can have latest data right then of what's going on in the community, the pulse of the community. And then third is there are APIs where this data can just be dropped into other kinds of analytic programs like Tableau or something like that, if you're fairly advanced in doing that kind of thing. But here's just a snapshot. So this is depicting a rural community, and your users are on the upper left, other rural communities on the upper right. These are people that have taken a substance misuse assessment. And for the most part, if you look at the bar graphs there, and those are ages, it's looking pretty similar, except there's one that clearly pops out, which is the ages between 18 and 24. This community has extremely high rates of higher acuity, people responding with higher acuity. And that would be of concern. If I was the health director in this community, I would absolutely be looking at that age group and targeting programs there. So that's the kind of thing, of insights that you can get. Okay, so we're going to do 2 things now. One is just talk about when you launch a system like this, it's not like everybody just knows about it and shows up. So what are the most innovative people and communities in the country doing to create awareness and engagement? And then what are the users saying and what insights are being derived? So that's where we're going. That's what we're going to share with you now. So we did an interesting analysis. We have these over 200 communities that are now using the platform. And we looked at the attributes of who we're working with and what they're doing, right? So how are they organized? Do they do chips and chaws? Are they FAB accredited? And here are the 5 things that correlate with high engagement in the community. One, that you work in a coalition. And it may seem obvious, but there are a lot of health departments that just might do this on their own. But when you're also working with behavioral health and law enforcement and schools and the United Way, and we could just keep going, and they're not just aware of this, as you'll see in a minute, they actually use this for their populations. This becomes integrated into the fabric of the community. So building a broad coalition, having a clear champion who actually thinks about this and wants to see this expand and look at data over time. local digital advertising, like local Google. A lot of people don't know this. You can run a Google ad and it can be geo-targeted for like your county. So that's a very efficient way financially to create awareness. Tapping into multiple channels of reach, that's very similar to the Broad Coalition. I'll talk more about that in a minute. And then keeping the message fresh and frequent. So we generate content every month that we just give you on the platform so that you don't have to go do all of that content generation. And so whether it's newsletters, social media campaigns, etc., you've already got the material to pump it out. And those kinds of things make a big difference. So it's time change, and you're telling people in your community how they can adjust more quickly, that kind of thing. So what happens when you are doing these kinds of things? The impact is dramatic. So first of all, we looked at all these 200 communities and we decided, let's look at the top quartile performers. So that means those that are scoring high with those 5 elements that we just discussed on the lower right. And let's look at the bottom quartile performers. Now, let's start with the bottom because they're still doing pretty good. They're since launch, so that's over the last 18 months, they've had on average 4% of the population, their residents, using the platform. That's good. I'm not here to say that's bad, but the top performers that are doing these things on the right, that are following best practices and being innovative, they've got over 10% of their population using the system, which is really meaningful. So we're absolutely learning what works to drive engagement. So I want to introduce you to some of these folks doing this innovation work. For those of you that were at NACCHO 360 this last summer, there was a talk that was given, and these 5 women, as far as I know, they met for the first time. They got along so well that they gave themselves a name, the Hope Sisters, because they're creating hope in their communities for a better day and a better life. And from Indiana to Colorado to Texas to South Carolina, they all came with their innovations and their stories. And so what are they doing? And I'm just going to take you through very quickly some of the stories that they've told that are really working. So one, kind of classic, you might have some billboards and come up with some creative messaging. It's okay not to be okay. These kinds of things so that people in the community see what's going on. In South Carolina, which happens to be a statewide implementation of this platform, they've integrated this early intervention and self-care for mental health into their 988 program. And a lot of others are now expressing great interest in this. In other words, people call into 988, and then as part of the response, obviously, if they are truly in crisis, they're being connected to crisis services. But as part of the follow-up, they're getting self-care tools for themselves, for family members, and others. So that's a very innovative program, and I think we're going to start seeing a lot more of that. Obviously, many of us have community events and fairs. I think one of the most creative things that I've seen are the use of QR codes. So in Farmington, Connecticut, they've got QR codes, and those are, and they take people to the site, of course, and they are being used they're integrating into the fabric of services of the community. Let me give a couple of examples of what I mean. Schools. A high schooler gets an ID card. On the back of the ID card is a QR code. You click, and you're now on a website which can help you with things like bullying, cutting, other topics that may be of concern to someone that's in high school. Law enforcement, when they come and they're engaged in activities which are often traumatic for individuals and families, they leave behind "We Care." And here are materials that are available to you to help work through whatever that issue might be. And it takes you to the website where you can get that kind of assistance. That's the way that you don't drive engagement by you work with local media, you can run ads, but at the end of the day, it's not just the health fair. That helps create awareness. It's when you do all of these things together and they're integrated into the services that social workers, caseworkers, law enforcement, schools, and others, that as they go about their work, they're using this system, that you suddenly have a true community resource and get dramatic engagement. Now, let's move from the engagement, which we're getting, to what are some of the insights? What's happening? Where's the value here? Many of us know the term meaningful use from healthcare delivery, but one of the things that, in the industry that people often talk about is clicks are really good. Clicks are fine, but clicks are just clicks. We care a lot more about, are people making positive behavior change? Are they finding a resource that they care about? So we've come up with this idea of when people come to the platform, what are they doing that's meaningful? And about 2/3 of people, and this isn't reported data, we're tracking this data, this is actual usage data, are doing things like completing an assessment or going into one of those topic centers or watching a video or listening to a podcast. In short, they're learning. And so that we're very excited about that. One of the things we're very interested in looking at when we have all of this data around the nation is, are we going to see many differences between urban and rural communities? And honestly, I thought we were. And I was a little surprised. Here, I'm just showing a few of the results. But burnout, depression, and anxiety, the urbans are in blue, it was slightly higher rates in the urban for these three areas, but not very much. The only thing that really jumped was substance misuse. There was 112% high. So these are people taking an assessment and then they have an acuity level, 112% higher risk, higher acuity level of on the assessment results around substance misuse. Now, those numbers are still fairly small in aggregate totals, so we're going to be watching this carefully. But that would be, again, an area of focus for me if I was wearing a public health hat in that area. And we already know from NAMI, so that's not our data. This lower right is just a reminder that we have 178% higher rates of suicidality in rural communities. So that's the only thing I would call out that we really saw looking at that difference. What do users say? They're saying really good things. So 94%, this is self-reported data, a poll that runs on the site. 94% say they like the resources. So it's thumbs up, I'd refer this to a friend. About 70% say they either feel better about themselves or they better understand their well-being. That may sound like a soft stat. When people feel better about themselves, their health outcomes are significantly better. It's a very important factor. It's a really encouraging piece. Over half saying they're learning a new skill or practice. But for me, the most important piece of data on this is that over half of users are saying they've made a positive behavior change. They're sleeping better. They are exercising more. They're drinking less. Whatever it is that they set out to do, they are making change that's impacting their lives in a positive way. We're very encouraged by what we'll call how users react to all of this. Perhaps the most intriguing insight that we have to share today is this, which is that when users come in to these assessments, and this is principally with organizations that are really emphasizing the triage aspect. It's not principally the front door of just self-care. It's really a triage system. We're setting the expectations with people for that. We are seeing something that is really good, which is, we'll call it a self-selection to the right place. Those that screen, they take assessments and they have low to moderate risk are 81% more likely than those at high risk to start going into self-care resources, which is exactly what we want them to do. And flip side is that those that are screening at higher risk are 33% more likely than those at low to moderate risk to start clicking into local services and resources. And the reason why that's so important, one, it's what people naturally want. Two, the professional services and local services are a lot more expensive. So, and they're overrun, as we've already said, with our 250,000 behavioral health shortage. So if we can have people in a community that are at low risk, not just make that phone call and they don't know any better, so they go into professional services, but if they can move into what they prefer, which is self-care, and people at higher risk are the ones that really get the seats, the available seats in professional services, we've done the whole community a tremendous service. So this is what we're seeing. This is the first time we've reported this data. We are delighted to see it. Okay, we're going to tell you one more story around some outcomes. I'm going to hand it over to Shamar. We did a project with Monterey County, and then we're just going to mop up and take questions. Shamar, over to you.
Thanks, Derek. I had the privilege of working with Monterey County Behavioral Health System in California to basically create the pilot version of Smart Screen as we described earlier. So in that county, the issue, as is across the rest of the nation, was a growing demand for services without a growth in staff, a big disparity between the supply and demand of mental health provision. And the goals for this project were to increase the community's awareness and access to not only the behavioral health system, but the other organizations and programs that were available to them in their community, and also awareness and access to psychoeducation and information of things that they can learn about themselves and what they can do on their own. Besides that, we also wanted to alleviate the burden on clinical screening. We were seeing that so much effort was spent on the intake process, and like Derek said, especially for the safety net provider that is really only meant and has capacity to take people who are at moderate to high acuity and don't have insurance or are on Medicaid. They're spending a lot of time kind of weeding out those people, referring them to other things that are more appropriate to them, time that could be spent on treatment for people who are currently eligible for those services. And then they also wanted to promote early detection and self-care, especially among underserved populations, addressing the equity issues between the different groups that are in need. Like Derek described, we created a solution where people can take an assessment and their results, they see how they're doing across a variety of areas and get connected to self-help as well as local community resources. After the first year of implementation, this is what we were able to see. This is research done by an independent analysis outside of Credible Mind. And the results showed that within that first year, the number of people that completed the assessment was 3 times the amount of people that were receiving services from the county behavioral health department. So within that time frame, there was a triple of the reach through this resource, connecting people to behavioral health services and information beyond what could be provided by the in-person offices. Within that group of people, we saw a great reach to youth, to Spanish speakers, which makes up over 50% of the county's population there, and also what we're calling high-risk community members. So of people who completed the survey or the screener, 61% scored in the moderate to severe risk category in both a behavioral health and a substance use risk area. So we're reaching people who are in significant need of receiving support and services through these resources and platforms. And then, despite seeing such a rise in the reach and accessibility to this information and these resources, the behavioral health system saw a slight decrease in cost. So even with more people being made aware of the services and opportunities available to them and more people seeking help, that did not increase the cost that and the burden that was put on the system.
And that third-party evaluation was done by UC Berkeley. They wrote a report. There's an executive summary of that evaluation if someone wants to get a copy of that. So let's wrap up here because I want to save some time for some questions and just say that, look, this platform and service is a community of innovation where we can benchmark and share best practices, drive engagement, and really learn more, become more data-driven and evidence-based for how we address mental health and being in the community. So what are some potential next steps here that I would counsel people, given all the folks that we work with around the country? The first is, if you're interested in, you may already be doing this, and you can still learn from some of these bullets, but if this is something you want to learn more about, think in terms of coalitions and partnerships. One of the questions we get all the time is, should this be led by public health or behavioral health? The short answer is yes. I would say we showed you today both the self-care principle functionality and the triage focused capabilities. And typically, it doesn't have to be this way. I would say public health probably should lead the self-care portion, and behavioral health departments might want to lead the triage piece because people end up getting triaged to them. But clearly that should be done together. Public health and behavioral health working together, along with other local stakeholders, is the best way to have a successful approach and make real impact in your community. This system gets localized to your community. You pick the languages you want, you pick the topics you want to focus on, you connect it to the referral patterns that you want. We can help you. We do this all over the place. We can help you with the questions to walk you through that. And then once you launch, you almost near immediately start having engagement and gaining insights. We have playbooks for how to get that awareness out there and materials to give you so you don't have to create all those billboards and social media campaigns and things. They're all teed up for you. And in terms of timeline, people are usually quite surprised. When someone contracts with us, we can launch within typically 2 weeks. So this isn't a months, this is weeks to start making positive impact in your community. By the way, the triage project is a bigger lift, and that doesn't launch in 2 weeks. So we had a second poll, and I want to run it quickly. If you were interested in this Behavioral Health 360 program, what would be the barriers? Let's learn what the challenges are. Okay, so big shock, funding's important. And I should point out, by the way, that we're always actively looking for grant sources, and sometimes we can connect people to grants. So you let us know if funding is the issue, we might be able to help. And then the coalition and organizational support. Okay, that no surprises there. It's really exciting for us here at Credible Mind and NACCHO to see how the buy-in has taken place with these 200 communities. And again, it's accelerating and we're learning from each other. So this idea of best practice sharing and learning how to get people using this, seeing that it's making positive impact, and then getting data into your hands to create insights that are specific to your community is really what's the most rewarding. And I think the triage, the Monterey story, is obviously a very big deal as well. So let's close here. Thank you for your attention on this. Let me know if people have put questions in the chat, but please fire away.
Yeah, thank you, Derek. That was great. Shamar, fantastic presentation. It's just really nice to see an evolution of diagnosing the problem, realizing there's a crisis, and now seeing the work that you guys have done over the past year and how that's been crystallized through some of the data and where we chart a pathway forward from here. So there was a couple of interesting questions. One that's come up a couple of times is around kind of using digital tools and maybe the linkage between social media influence on mental health. I'm curious about what you make between those linkages. They cited a few authors, Brian Primack, Gene Twenge, Jonathan Haidt, etc. So would love to hear. I'm sure you run into this question a number of times.
Yeah. And Shamar, I'll give, given time, I'll just do some quick answers, but you jump in wherever you want. I think social media and digital media at large is just a mixed bag, right? It's like how you use it. And you have to meet people where they are. And if you let people just all they see in social media is what you typically see in social media, then they're going to have a lot of the poor related information that they get. But there are a lot of positive things that can happen through social media. And I guess my response is get in the game. You want to be there with a responsible message and tools that are really valuable.
That's great. There's another question here around, does the site have any ability to compare who takes assessments with community demographics, i.e. how representative of the community are the users of the site?
So there's a very interesting thing. People can allow the residents to come in and use the system completely anonymously, which most communities do. And there we can capture some information of demographics because we ask the question. We don't know personally identifiable information. We can ask about certain things like age. And so we can actually work with our local communities to add some questions. So the answer is a qualified yes in an anonymous setting. Now, you can also turn this on behind a firewall with login. And I will say with some surprise, we thought that would kill traffic and activity, not as much as you might think. So there are some pros and cons to think about that. And if you do have single sign-on or some sort of a login, and you can use your like Google login or whatever, so you don't have to remember passwords, there's more information that you can capture.
That's great. Another question here is, although it's been relatively new, do you have any data on community health outcomes in these communities, such as ED visits for BH, suicide, overdose, etc.?
No. It's the question answered itself. It's just a question of time. Where we've gotten is phase one was launch, do people come? Yes. Two, are they doing meaningful use? Yes. Three, we now did this independent evaluation on understanding what we're calling this triage effect, and that you can increase access in a community and reach people that are hard to reach, youth and people with high acuity, and not increase costs. That's as far as we've got. We've given you what we've got. Next step needs to be to start tying this back to some of the objective utilization measures. And we relish that kind of partnership. We'd love anyone who's listening today and wants to work with us. That would be an excellent project.
Another question here is around behavioral health 360 access to marginalized populations without access to digital devices, right? A lot of times those folks have the highest risk of behavioral health conditions, for instance, the unhoused population. How would communities thinking about implementing this platform approach this? How has your team and the platform gone about approaching that particular demographic?
Yeah, I can quickly respond to this. So, first of all, it's a problem, clearly. And I teach health informatics at UC Berkeley. I just gave a lecture last week, so it's fresh in my head. About 93% of Americans are online and connected. So, most people have digital access, and we already talked earlier about how critical it is to be available through mobile. But for those that don't, like the unhoused, the key is to go through some sort of a human mediated process, putting this in libraries, into the hands of social workers, etc. And we absolutely have cases of like social workers using our system and being proactive with people to help them gain access to this kind of information. It's hard, but it's doable.
I know we're running a little bit over. I think we have time for one more question. There was a question around how the Boston Public Health Commission, their particular, has equity as one of its core aspects of their mission. Can you speak to how not to only address increased access, but also how to ensure equity and supportive cultural competence, such as stigma related to use of mental health systems, lack of fit, lack of providers with similar identities, et cetera?
Yeah, absolutely. So health equity is a broad topic, right? So we talked briefly around there's awareness, there's access, there's how do you reach people? So a lot of times it's through social media, digital campaigns, talking to local media, all of that. There's the languages, obviously, that we talked about. There's also the topics that we cover. I didn't go into it today, there wasn't time, but there's a whole personalization, both option for an end user to select. So you can select content, say, as a person of color that wants to hear about the stories and people that look and feel like them around topics like stress, anxiety, housing, etc. So there's content in the system that directly helps address some of those issues, and it's a never-ending process. And then, of course, there's the organizations that you choose to work with. So that's really getting into the community so that those people that basically the people that can use this are being made aware of it at the time where the need might be there, like in school. Those are some of the things that we're doing now. I'm sure there are more. I'm not familiar with all the programs.
Yeah. I think it's a good place to wrap. Again, I want to thank Derek and Shamar. Did a fantastic job talking about this particular platform, how it's really revitalizing a lot of our efforts to address mental health and the behavioral crisis that's going on in our communities and how the work they're doing with local health departments. We will again be making this both recording, audio and video available directly after, as well as the presentation slides. So please share with any of your colleagues that may have missed it. And the Credible Mind team will be reaching out to any folks we didn't get to answer any of the questions on to see if there's any additional feedback. So again, thank you very much for your time. We really appreciate it. And we look forward to all of you helping us figure out how to tackle this mental health crisis and be able to create solutions for our community together. So thank you very much. Have a great rest of your day.
Sebastian, thanks to NACCHO again for your leadership.
Cheers. Bye-bye.
Bye.